Hey, welcome to the Clinical Cousins YouTube channel. Today's video is going to be on hyperkalemia and its management. This is probably one of the biggest mismanaged disorders of electrolytes I see in the hospital. I've worked in the ICU and ER and CVICU for years, over a decade, without giving away my age. And I see this mismanaged by providers. I see it mismanaged by when we get protocols. A lot of times we don't know what do we do first and why we do it first. So that can leave the patient a little bit of danger. And I think with a little education, this will become very intuitive for how you manage it. Now at the beginning, I am going to go into a little bit on resting membrane potential, electric membrane potential. We have some videos on that my cousin Christian did. If you would, just refer to those videos. If you want to go in any deeper, it'll go into the nurse equilibrium equation, cellular physiology, and those things. But we're going to just do a brief little dive into that, but not super deep. And then we're going to get into the management. And I promise if you use this, you will see it. Probably if you're working ICU or ER, you're going to see this within a week or two. And knowing this, you're going to handle those cases better, smoother. You're going to know why you're doing things the way you're doing them. Especially, there's a lot of disorders that can cause hyperkalemia. But if you get a dialysis patient in, you're going to find out why. As ER or ICU, if that patient comes up, you're going to know I'm going to need on them an EKG and I'm going to need to get their labs back fast. They're going to be a priority because this is deadly. Other conditions, acute renal failure, and those two, also someone says I haven't made urine in a while, I need an EKG. We're going to need a 12-lead EKG, and we're going to need to get their labs. I don't care if they're a hard stick, they're going to be our priority because this is something we can fix early. If we wait till later, we're in a lot of trouble, and we're using our ACLS protocols, and when we probably don't need to be doing that if we can catch it on the front end. So on why we need potassium. Potassium is found in abundance inside the cell, but on the outside of the cell, there's not as much there. And it's the opposite with sodium. We have a ton of sodium in the extracellular fluid. We have very little inside the cell. So our sodium, potassium, ATP pumps are constantly keeping this balance of potassium in the cell and sodium outside the cell. So it actually creates this negative resting membrane potential. So it keeps this negative, almost like charge there. So we've got all these positive cations with sodium and the number of 135 to 145 milliequivalents per liter outside the cell, with only like 3 to 5.1 milliequivalents per liter inside the cell. So we have all this sodium. It's wanting to rush into the cell, but it can't. And when it rushes in the cell and makes this cell jump into a positive manner, that's when we get the firing of these electron membrane potentials, or that electrical firing, because that positive cation rushes into the cell and it polarizes and depolarizes these cells and causes even the electrical activity we'll see here in a minute on an EKG. So normally it rests around a negative 85 millivolts. So it's doing that through those pumps and exchanging those cations out. So what happens is our cells, especially in our pacemaker cells and cells of our heart, they're slowly leaking out certain cations. So the charge here is slowly approaching this. So slowly the cell's becoming more positive. Well, when the cell reaches negative 65 millivolts within it, there's these little gates, they're called voltage-gated sodium channels, that when they hit this certain charge, they just fling open and sodium rushes in. And when sodium rushes in, it causes that positive charge. It causes all that positive energy to come in, and it changes this from negative more to positive. Of course, it flips back over and locks, and then those pumps restore it back to normal. So that's how we get that pacemaker activity of the heart. Also, when we touch here, we push and distort these little sodium channels that let some sodium rush in, and then as soon as it hits this, the charge gets positive enough, it sends opens those channels up, and the same thing happens, and that signal goes to our brain. It stimulates, tells us we've been touched. So that's why potassium's so important. So if we get hyperkalemia, what ends up happening is this resting membrane potential comes closer and closer to threshold, so it's easier to fire. So intuitively you would think, okay, if it gets more positive, it's going to get closer to this, it's going to get really irritable. And that's true in the beginning. The problem is if it doesn't reset low enough, the charge doesn't go low enough, we get these voltage-gated sodium channels, they get stuck. So now sodium can't rush into the cell when they get stuck, when your potassium gets too high. So when your potassium gets too high and those channels are stuck, no electrical activity can take place. And what happens is the heart becomes paralyzed. It can't move and the patient dies. So the changes we usually see, and the biggest one that's talked about in medical schools and nursing schools and school for physician's assistants is these peaked T waves. It's true we get them. Normally they're seen more in the precordial leads, V1 through V6, so they can sort of hide in some of those in your 5-limb leads there. And it is troublesome. If you see this, you know you've got a problem. But your real problem comes when the higher the potassium gets, the wider your complex actually goes out. So when you start seeing your complex widen out, it almost looks like you have a bundle branch block appearance out of nowhere, or suddenly you develop a first-degree AV block in a patient who's hyperkalemic. That's the more worrisome sign, because when you get here, you're getting close to all those voltage-gated sodium channels are stuck, and the heart is going to become paralyzed, and nothing you can do can get that electrical activity you need to get that mechanical contraction. So I've wrote some of the normal labs that are associated a lot of times with the changes till we get to the classic sine wave PEA pattern. Usually around when you get a little bit above 5, normal is 3.5 to 5.1. When we get a little between 5.5 and 6.5, that's when we see these tall peaked T waves. As we get higher and we get closer to 7, we'll start to see our P wave flatten out. And the way I learned this is it's like a string. So if we take the string here, and when we first start to get hyperkalemic, sort of pushed in, so it's everything's peaked up. As we go, we're pulling the string out tighter. So the higher your potassium goes, the more that string's pulled out tight until it's a flat line and the patient dies. So what we look for is if we see their QRS complex on a patient, we get their labs back and they're hyperkalemic, and especially our dialysis patients, our acute renal failure patients, although hyperrenemic, hypoaldosteronism, potassium supplementations, potassium sparing diuretics, ACE inhibitors. There's a lot of causes of why you can get that rhabdomyolysis, but especially in those dialysis patients or acute renal failure patients, if we get back their labs and we see some of these numbers, or we see these on the EKG, or we've got what looks like a bundle branch block appearance, but it hopefully, you know, we're learning to read those too if you're going to take your CCRN. But if you get that big S wave here on your V1, you go, oh, it's wide, it's greater than 120 milliseconds, that looks like a left bundle branch block. But then you also got in V6, it's downward pointing, it should be an upward pointing monomorphic R wave, especially on the terminal portion. And we have this, it suddenly doesn't meet the criteria for that bundle branch block. Well, the reason is you're probably going along this pathway, and it's causing what's called an interventricular conduction delay. If you ever see these, a lot of times the doc will come in, you'll have a dialysis patient, they'll first see them, they'll look on the board, their heart rate's at 100, 105, and they have this wide appearance, and the first thought's VTAC. And that's okay, because that's a deadly rhythm, we need to manage it. But in our renal failure patients, we need to also think, is this interventricular conduction delay because their potassium's through the roof? So we need to get those labs drawn. And sometimes they may say, and we'll find out in a minute, just go ahead and give some calcium gluconate, just in case this is what we're dealing with. So anytime you see something that's a wide complex, and it's not a VTAC, and it's not matching up with your bundle branch blocks, it could be nothing, but you need to rule out hyperkalemia, and tricyclic antidepressants can also cause that. So just remember the string as it's pulled out, of course the peak T waves, but if you start getting wide complexes and your P wave starts disappearing, you better act fast. And that's why we have this mnemonic here. The mnemonic we'll use, and it'll save lives, and you won't miss part of the treatment, is IC big K drop. All the letters in red represent treatments we'll do. I is for IV fluids, C is for calcium gluconate, calcium chloride, B is for bicarb, insulin, glucose, K for the K that we want to see drop is potassium, and the D in drop is for dialysis and diuretics. So the order we do these in is also very important. So we establish IV access on this hyperkalemic patient. We've got that EKG, we're seeing some changes, and the doctor says I need a shift. Now, there are conditions like DKA and acidosis where if we manage those acidosis, the acidosis or the DKA, then the potassium will lower anyway. But we're talking about those cases with like dialysis patients, acute renal failure patients, people with crush injuries. So we're going to start with IV fluids. Now we need to make sure they're not fluid overloaded because maybe they missed a bunch of dialysis appointments. But if IV fluids ordered, it can be a good option because it will act to dilute. If I have half a milligram of salt in 2 mLs of water, I get a half concentration. If I have 4 mLs of water with the same concentration of salt, I have less. So by default, it can sort of dilute. It can also help excrete, kick the kidneys back into working in patients that may be in an acute renal failure. So in patients with rhabdo, of course, we use a bicarb solution too with them, but it can help start excreting that myoglobin, trying to help clear the kidneys so they can get back functioning and clear some of that out, so where they've had lost cells and things, so it can bring the potassium down. So IV fluids works in minutes to hours. So we have the IV fluids going, we've got IV access. Which should we do first? Should we do the insulin, K-Xylate, diuretics? Should we give them albuterol, bicarbonate? Well, I've got it right here. So the first thing we want to do is stabilize that cardiac membrane because we don't want them, their heart becoming paralyzed. We don't want them going in cardiac arrest. So the first thing we need to do is give calcium. And the reason why is it stabilizes that cardiac membrane potential. We have videos on that. You can watch if you want to go deeper on that. So big take home point, if I can get to any of these first, I'm going to give this. It's going to start working in minutes. The next one that works fast is we want to shift the potassium, and we know insulin. Insulin helps shift potassium inside the cell. So not only does it help pull the glucose, it also helps pull the potassium in. So this one also works in about 10 to 20 minutes. So this is very fast as well. So our calcium and our insulin, we want to give those immediately because this can progress very fast. We don't want to wait. We don't have time. So we don't want to go in there and push bicarb and say, oh, I'll come back in and do this other part later. No, we've got to act immediately. So we're going to push the calcium, and we want to start with the insulin. Usually it's 10 units of regular insulin with an amp of D50. The docs can and providers can have some leadway there on the dosing on this. Now, also what we're going to see on this is if you don't have regular insulin, you can push log insulin. If it's clear, it can be pushed. We don't want to push the long-acting insulins. I learned in nursing school it's just regular insulin you can push. In our drips, that's all we have. But if you have Lispro, it can go in IV as well. Of course, consult with pharmacy and your provider as well. That one I had to learn the hard way when I refused to push it on a patient, and pharmacy educated me, which I was very glad on years ago. So next, bicarb is something we see done a lot. Honestly, the studies show that if they're not in a state of acidosis, it really doesn't do a lot, and it usually takes several hours to actually get any type of change or shifting. What it does, it shifts the hydrogen ions. It combines with the hydrogen ions, so then your body, as you go into states of more alkalosis, it wants to throw out a hydrogen ion out of the cell and pull in a potassium to sort of balance that, a positive for a positive charge, therefore reducing your potassium. However, recent studies, you can look on Up to Date and other websites, say that unless you're in states of severe acidosis, this isn't a quick fix, and it may not be useful at all. It's probably not going to hurt anything. All right, so our other option to do shifting after that, so if we had to put in order, we would put these as our number 1. We would put that as our number 2. The other option we have is using a beta-2 agonist like albuterol. Breathing treatments will work to potassium shift. Now, they take up to 90 minutes to get a shift that's meaningful, so they're a little slower. They do work. The only issue you'll see a lot of times, people order a regular breathing treatment. You really have to have 10 to 20 milligrams of albuterol put in about 4 mLs of fluid, which is going to make your patient pretty nervous and shaky. But a lot of times a normal dose albuterol breathing treatment will do nothing. So it's got to be high dose to get any meaningful effect out of it. So these are your first steps in management. Now, this one you can also do while you're at it, but if you need to get to your calcium, you need to get your insulin glucose for your shift. So once you shift the potassium, it means you've lowered it, you've shifted it intercellularly, and so you feel good. You've reduced your potassium some. The problem with just shifting and doing these shift protocols without excreting or finding some way to bind and get rid of them or send them to dialysis is over a few hours, even to an hour, it will start shifting back. All the process that caused this problem still exists. These protocols here buy you time. They do not treat the patient. They don't treat the potassium and lower it permanently. This one probably does to a degree, but these other things we do for potassium shift do not take the problem away. They buy you time. So please look at these as time buyers and not as a fix. So these will help shift it so that you're not in cardiac arrest, but given enough time, everything will go back to the way it was. So now we need to find out, why are they holding on the potassium? How can we get rid of it? And that's where these protocols come in, which take several hours unless you're looking at dialysis, which is immediate. So I give these so I immediately treat my patient and hopefully prevent this progression to cardiac arrest. And then I'm going to start giving my K-Exolate, which is going to rid it, which the problem with it was it gave a lot of diarrhea. And now we have a new medicine that binds to the potassium called Lokelma. We don't get the diarrhea with it, but both of these take several hours. So I want to do this as fast as possible to shift that potassium, to stabilize that cardiac membrane potential so that I don't end up in cardiac arrest. And as soon as I know they have a high potassium, I need to act fast because I don't have a lot of time. I need to immediately assess any dialysis patients I have, acute renal failure patients I have. All of them need an immediate EKG, just like you would do with a cardiac patient with chest pain. They all need an EKG, and they all need their labs drawn immediately, especially if they say, I've got a lot of weakness, because as this approaches threshold, it's harder to fire membrane potentials. It's harder to get the firing of those, and it causes weakness. The same as if your potassium goes too low, it drops this number really low. So now it's harder to reach threshold to fire, so you get extreme weakness, and you can end up in trouble with your heart becoming paralyzed or going into arrhythmias in a different manner. So we shift it, and now we need to rid it. So K-Exolate, Lokelma, we need to get on the ball. We need to get these in our patients fast so we can get them to excrete it. If it looks like they're in fluid overload and they've missed a ton of dialysis and their potassium's super high and we feel like we've shifted on some and we're ridding some, but they're probably still in some trouble, we need to get a hold and potentially get a hold of the dialysis team to get emergent dialysis. Now, if it were something that, and we rarely ever do this, that it was a problem with excretion, we could give diuretics if their kidneys were still functioning okay, and that'll start working in about 15 minutes. But our D in this is for dialysis. So we'll go to this one more time. Our hyperkalemia management is going to be IC big K drop, IC big potassium drop. It's IV fluids, calcium gluconate, bicarb, insulin, glucose, K-Exolate or Lokelma, dialysis, and diuretics. So this is the Clinical Cousins YouTube channel. If you would, please like or subscribe, and we're going to have some more content up shortly. Thank you.